Welcome to Eye Contact. I'm David Spalton. Today we're talking to Professor Rudy Nuijts, who has just been elected as the next president of the ESCRS. So many congratulations, Rudy.
Thank you, David.
You're also going to be giving the Ridley Medal lecture tomorrow, which is the highest academic award that the Society can give. Would you like to tell us what you're going to talk about?
Yeah, the title of the lecture, David, is actually Facts First, and that refers to the search for evidence into the innovations that we have, some of the innovations that we've made into anterior segment surgery. I think it's of paramount importance that if we bring innovations into our field, that they are being adequately researched to see whether they are real innovations and whether they also can be approved to implement them in regular care pathways. Because that's important, of course.
So what we're talking about is evidence-based medicine.
That's what we are talking about.
Yes.
Traditionally, of course, our actions were based on what we call eminence-based opinions from leading surgeons like Ridley and so on. But that has been changed over the years a little bit into evidence-based medicine, where we really also look to numbers. So the integration actually of clinical practice, clinical experience, and the evidence base from science is very important. And traditionally we used, of course, randomized clinical trial, meta-analysis, but now we also have the resources like big data, artificial intelligence, which are going to be more and more important.
So really this is a field which is moving extremely fast, really, isn't it? This last year you completed the Premed study on prevention of cystoid macular edema, which is a major milestone, I think, in evidence-based medicine for management of cataract patients. Would you like to just recap?
Yeah, so we had the Premed study, as you know, was funded by the ESCRS and consisted actually of two trials. One was looking at the best preventive measures actually for cystoid macular edema in a routine population of cataract patients, and the other part of the trial was looking at diabetic patients. And what we figured out in the routine cataract patients actually is that the combination of an NSAID and corticosteroids leads actually to the lowest incidence of clinically significant macular edema. It was 1.5% for the combination versus 5.6% for the steroids and 3.6% for the NSAID.
A very significant difference between the two groups.
Very significant difference. And this is a perfect illustration of why evidence-based medicine is important here, because we also have, as you know, the ESCRS clinical survey instrument that actually asks our colleagues questions about what their practice patterns are. And if we ask our colleagues if they use NSAIDs nowadays, it's 20% actually that don't use NSAIDs. And I think this is a clear example of how we can change our daily practice actually by implementing this scientific result.
It's quite difficult to get people to change their routine care, isn't it? I mean, how do we approach that to get these ideas over into we have to get into clinical practice, don't we?
Well, I think you have to, after a study like this, you have to formulate recommendations, you have to set out guidelines, and then, like in many countries, also in the Netherlands, we have our guidelines that are being revisited every 5 years. So we have cataract guidelines, and it's important that in these guidelines, actually, these results of this science are being implemented and go into the daily care routine of the surgeons, because otherwise we do science and nothing happens.
Yes. Do you find that works in the Netherlands? It's quite difficult. I mean, certainly in the UK to get people to change, we don't really have, the national guidelines don't really exist.
Okay, yeah, well, we have that. So we have our ophthalmological society that has guidelines for cataract surgery. And I think actually that it is possible to change it, because people are paying much more attention nowadays to these guidelines. It becomes more and more important. Also in the communication with insurance companies, actually, because they judge you on how you do your work nowadays and how you work according to certain guidelines.
One of the other areas which you've been very involved with is in the management of astigmatism and toric lenses, isn't it? Where you've also done an enormous amount of research in that area.
Yeah. I think actually, and this is also a perfect example of why you should do that. So in 2006, I performed the first toric IOL implantation actually in the Netherlands. And it took us until 2014 before it was approved by the national institutions. And why is that important? Because before that, you were officially not allowed to do it into the basic care. So based on the approval that toric IOLs are safe and effective, we could get it into the basic care system, but since it was not cost effective, actually, they were not going to pay for the additional money that is involved in toric IOLs. So we had a co-payment system that was actually tolerated by the government. So this is a perfect example of what you should do in terms of evidence-based medicine to get it into the market and to implement that into the system. And what I would plea for is that there is, in a much earlier phase, good cooperation between industry and doctors to design adequately the trials that are needed and that answer the questions, to bring that circle from innovation to implementation in the market, to make that circle much shorter.
One of the problems that we have is the amount of regulation, isn't it? Because facts count, but on the other hand, we need to get technology out there to be used as quickly as possible. But the regulation actually is a substantial expense and a big break on getting things into clinical practice. Do you have any views about how we can manage that?
Yeah, well, I think that it is a break, but it is also necessary, I think. I mean, we have seen, I mean, the graveyard of ex-innovations. There is a famous doctor from the Netherlands, actually, who is now actually the CEO of UCL in London, Marcel Levy, actually, who said, you know, there is a graveyard of ex-innovations, and we should prevent them to bring them to the market. And well, we have all kind of examples in anterior segment surgery. I won't tell them now, I'll give examples, you know, where a lot of money is being put into by the industry and also by the doctors, and at the end of the day, we find out it doesn't work. And I think at all costs we should try to prevent that and to put the money in the adequate resources of those things that really work.
One of the things that you do have in the Netherlands is a sort of world experience of phakic lenses, isn't it? Going back to the days of Jan Worst and the artisan lenses. I mean, you've got more experience there probably than almost anywhere else in the world with those patients.
Yeah, so we start, actually, I myself started with the artisan fixated lenses in 98, actually. And what I decided at that moment is that we were going to follow these patients long term, which means that we set up an endothelial cell study using the same specular microscope for all these years. So we have not changed that.
Massive data.
Massive data, and that gives us a unique manner to compare long-term data. Because if you look at the literature of phakic IOLs, most of the studies are very short, long-term, and we know that the changes here are only going to occur after many years. So there is a study that shows actually after 10 years you find out that the endothelial cell counts go down, and that's the moment actually that it becomes important because many of these patients are young, of course. It is of utmost importance to follow that. And what we've seen actually is that following certain criteria, that after 10 years, 1% of the lenses are explanted, but the years thereafter, it goes quite significantly up, actually.
And as you point out, it's terribly important because these are young patients who have got a long life expectancy with high refractive errors and
I don't want to scare people. That's not needed. But I mean, the message that should go out there is that you need to follow these patients, especially long term. So don't implant the lens and then send them away. But especially after 8-10 years, I mean, call them in and have a look at the endothelial cell counts.
Rudy, thank you very much for joining us.
Welcome, David.
For more information on this and related topics, please visit us at EUROTIMES.org.